Hello everyone, this is Dr. Pritpal Singh, and today I would be talking about the drugs used for acid-peptic disorder. And these particular drugs or this particular uh, text comes, if we talk about the new curriculum, it comes under the competency 1.34, where we need to talk about the types, the mechanism of action, the doses, the adverse effects, the indications and contraindications of drugs that are used for acid peptic disorder and GERD. So we would be talking about this particular topic in these particular headings. We would try to talk about all the drugs that are there. And I hope after the end of this session, uh, it would be able to clear some air on this particular topic. So proceeding further with the drugs that we have, now we need to start with uh, the basic steps or the basic pathophysiology that is involved in production of acid. Now, the gastric acid secretion is regulated by uh, acetylcholine, histamine, gastrin, and prostaglandin E2. And then there are various phases of gastric acid secretion, which include the basic phase, basal phase, the cephalic phase, and the hormonal phase. And this is mainly produced by the membrane-bound proton pumps, which are activated as proton hydrogen potassium ATPase. Now, if we look into this particular figure, what do we find? When we look into this particular area, this is where the ulcer is. What you find is that this particular area, the surface, as compared to this area, there is smooth and glistening surface. Out here, the surface is rough and it does not match with the surrounding. So this is an area of ulcer, and as we go by the definition of ulcer, it is a breach in the continuity of the skin or mucous membrane. Now, this peptic ulcer disease refers to ulceration of mucosa anywhere in the GIT tract that is exposed to acid and pepsin. Although the most common area that is exposed is the pyloric area and the first part of the duodenum. It could even have area involving the esophagus, and sometimes even Meckel's diverticulum is also involved. And these peptic ulcers could range in size from few millimeters to few centimeters, and it is estimated that 10% of the Americans will develop peptic ulcer disease in their lifetime. The two most common forms or location of peptic ulcer disease are the duodenal ulcer and the gastric ulcer. So duodenal ulcer is the most common type form of peptic ulcer disease, and it is 3 times more common than the gastric ulcer, and normally or usually located in the duodenal bulb of the small intestine or first part of the duodenum, and commonly seen in people between the age of 30 to 50 years. Whereas if we talk about the gastric ulcers, they are less common as compared to duodenal ulcer, located mainly along the lesser curvature of the antrum, and it's commonly seen in people greater than 60 years of age. Now, talking about the pathophysiology, gastric ulcer, in the gastric ulcer, it would always be, it is always one of the pathophysiology that is suggested is that the acid secretion is either normal or towards the lower side. Whereas in duodenal ulcer, the acid secretion is either high or normal. So then why, if it is normal, why only a few selected people have peptic ulcer? We would try to solve this particular aspect, and then we would be able to get a better insight into the drugs that act via for peptic ulcer disease. So this peptic ulcer disease is believed to be an imbalance between the defensive and aggressive factors. So what are these defensive factors first? The defensive factors are those factors that prevent the stomach and duodenum from self-digestion, which include the mucus, which has high amount of prostaglandins, the bicarbonate, which forms a layer in the stomach, so that acid does not digest the stomach. The blood flow, there is high blood flow, and prostaglandins, they tend to stimulate the secretion of bicarbonate and mucus and promote blood flow, as well as they tend to also suppress the gastric acid secretion. Now let's talk about certain aggressive factors. Now earlier it was believed that no particular bacteria can survive in an acidic environment. Thanks to some outbreaking research in the field, in this particular field. Now we have a factor that is implicated as one of the causative agents for peptic ulcer, and this particular agent is the Helicobacter pylori. Now, this Helicobacter pylori, whenever there is inflammatory response, it tends to produce urea, and this urease causes release of carbon dioxide and ammonia, which is toxic to the mucosa. The gastric acid, obviously, injurious to health. If there's a decreased blood flow, vis-a-vis compare, there's a defensive factor than increased blood flow. The non-steroidal anti-inflammatory drugs, they tend to decrease the prostaglandin production, and they are one of the factors that tend to lead to acid-peptic disorder and smoking, because it is said that nicotine tends to stimulate the gastric acid production. So the treatment approaches that we tend to follow are either we tend to reduce the gastric acid secretion, or we could neutralize the gastric acid secretion. We could use ulcer protective drugs. We could use ulcer relief drugs, and an approach that is now followed is giving an anti-H. pylori drug. So now let's talk about the various anti-ulcer drugs that are there. The anti-ulcer drugs can be categorized as proton pump inhibitors, the anticholinergic drugs, the antacids, the histamine blockers, the pepsin inhibitors, and the prostaglandin E1 analogs. So if we want to compare it with the approach wise, we are talking about the first approach, that was reduction in gastric acid. We have certain drugs that tend to reduce the gastric acid secretion, which includes the H2 antihistaminic drugs, which are cimetidine, ranitidine, famotidine, the proton pump inhibitors, the anticholinergics such as pyrazipine, propanetholone, and oxyphenonium, the prostaglandin analogs such as misoprostol. We have another approach that is there, that is neutralization of the gastric acid, where we tend to use antacids, which could be either systemic, such as sodium bicarbonate or sodium citrate, or it could be non-systemic, which includes magnesium hydroxide, magnesium trisilicate, aluminum hydroxide, megaldrate, and calcium carbonate. Or we could go for ulcer protective drugs. The drugs belonging to this particular class is sucralfate and colloidal bismuth substrate. We could use ulcer healing drugs such as carbenoxolone sodium, or we could use antimicrobials, which are mainly used as anti-H. pylori drug, which has a wide variety of drugs in it, which includes drugs from different classes such as amoxicillin, clarithromycin, metronidazole, tinidazole, and tetracycline. Now, when we talk about the regulation of gastric acid secretion, vagus nerve tends to act on acetylcholine. This acetylcholine then acts on histamine receptors, and histamine receptors tend to cause hydrochloric acid. So anticholinergic drugs, they tend to act by blocking this particular response. Histamine acetylcholine further leads to this particular block, so this is where histamine blockers are used. Once histamine receptor is activated, proton pump inhibitors, so proton pump inhibitors are used out here. Once acid is produced, we have antacids and prostaglandin analogs that can be used out here. Now let's talk about these mechanisms. Now this is a typical parietal cell which has a muscarinic receptor, a prostaglandin receptor, a histamine receptor, and a gastrin receptor, and this is a proton pump, and the hydrogen potassium ATP is located out here. So what happens? Let's see first. First is gastrin tends to bind to this particular receptor. It leads to release of calcium ion. This calcium ion leads to activation of protein kinase. This protein kinase tends to increase the proton pump activation, thereby causing secretion of gastric acids. Now let's see what histamine receptors do. Histamine binds to H2 receptor, which is the G protein couple receptor, which tends to activate cyclic AMP. This activation of cyclic AMP leads to further activation of protein kinase. And once protein kinase is activated, again it leads to activation of proton pump. Now, if we talk about the prostaglandin analogs, the prostaglandin E2 analog, it tends to bind this particular G protein couple receptor. It is an inhibitory stimulator, so it does not activate ATP, and hence no action is there. Talking about the acetylcholine, it tends to bind to this muscarinic receptor, the M3 receptor present out here. This M3 receptor releases calcium. This calcium binds to protein kinase. Protein kinase gets activated, and there is activation of proton pump, leading to secretion of gastric acid. So antacids bind to this particular gastric acid. ranitidine binds to, or H2 antihistaminic drugs bind to this particular H2 receptor. We have omeprazole binding to the proton pump inhibitor, misoprostol binding to the prostaglandin analog, having a positive impact. We have proglumide, which binds to the gastrin receptor. So now coming to the treatment or therapy or goal of treatment, the choice of treatment would depend upon the etiology, whether it is due to the H. pylori or NSAID, and whether treatment is for any, whether it is a case of an initial management or it is a case of prevention of recurrence of peptic ulcer. So the overall goal of this particular drug is we would like to relieve pain, we would like to heal the ulcer, we would like to prevent recurrences, and to prevent or reduce complications that is there with this particular peptic ulcer. So first we should obviously, because we are talking about drugs, but non-pharmacological therapy does has its own role. So this non-pharmacological therapy that has its role is you should reduce the amount of stress, smoking cessation, reduce the use of NSAIDs, and avoid foods that cause dyspepsia. So all these things are possible if we try to follow it. Now we don't talk about the first drugs that tend to reduce the gastric acid secretion, that is the anticholinergic drugs. And these drugs, they tend to decrease the gastric juices. Paranzepine has been approved in the Europe. We have another drug, telanzepine. These are selective M1 receptor blockers. They tend to inhibit acid secretion, but they are not used because of low efficacy and marked anticholinergic effects on other body parts. Then what are the drugs that we have? Histamine or H2 receptor antagonist are the drugs that are used. We have cimetidine, ranitidine, and famotidine, which are highly selective as they do not have any action on the H1 receptor. And these drugs, they tend to reversibly bind to the H2 receptor. So that means that this particular receptor is intact and they do not tend to change the configuration of this particular receptor. How do they act? They block histamine-induced gastric secretion. So what happens with that is the volume and pepsin secretion both decrease, and they tend to suppress all the phases of secretion that we have been talking about: the basal phase, the psychic phase, the neurogenic phase, and the gastric phase. And it is maximally effective in inhibiting nocturnal acid secretion. It also tends to suppress secretory response to non-histamine-induced stimuli such as meals, gastrin, acetylcholine, alcohol, and insulin. The adverse effects associated with these H2 receptor antagonists are very mild, and most commonly encountered are headache and dizziness. The usage of this particular drug is long. We tend to use it in obviously acid-peptic disorders such as duodenal and gastric ulcer. We can use it in stress ulcer and gastritis. We can use it in Zollinger-Ellison syndrome, which is a gastrin producing secreting tumor. We could use it in gastroesophageal reflux disorders, or we could use it as a prophylaxis for aspiration pneumonia preoperatively as a part of a pre-anesthetic medication. The other drug that we tend to use is the proton pump inhibitor, which is the most effective drug that is used in as an anti-ulcer therapy. Now, this particular drug is a drug that tends to markedly decrease gastric acid secretion because it blocks the hydrogen potassium ATPase. All the pathways that we were talking about, whether be it gastrin, be it histamine, be it acetylcholine, they activated the proton pump. This proton pump is inhibited, and this particular drug is an irreversible inhibitor of this particular enzyme. So until fresh set of enzyme is produced, this particular drug tends to have its effect. And the fresh set of enzyme, it takes around 24 hours for production of the fresh set of enzyme. And these particular group of drugs are always active at a pH of less than 5. The drugs that are used are omeprazole, which is used as 20 milligram once daily. As omeprazole, we could use also lansoprazole, which is used as 30 milligram once daily. Pantoprazole could be used as 40 milligram once daily. This particular drug is said to be more acid stable, has a higher bioavailability, and is also available for the parenteral administration. Rabiprazole is the fastest acting drug in this particular category. Now, these drugs are used as enteric coated granules or tablets. And why they are used? Because these drugs, they have to act from within the lumen. They have to first enter the cell, and then only they'll be able to act. They will be able to have their action. The half-life of this particular drug is 1.5 hours, and the best time to give this particular drug would be 1 hour before the meal, because it requires acid production. We talked about this. The pH should be less than 5. food decreases bioavailability, and meals, they tend to activate this hydrogen potassium ATPase pump and makes it more susceptible to proton pump inhibitors. Now, these proton pump is the potassium, hydrogen potassium is a membrane-bound enzyme, and it is said to play an important role in the final step of gastric secretion, whether it is basal or stimulated. Omeprazole is a prototype drug, and these drugs are activated to sulfonamide acidic pH. That is why an acidic pH is required, and they bind covalent with the SH group of the hydrogen pump and thereby irreversibly inactivating it. They should be administered orally 30 minutes, and some books even say 1 hour, and half-life is 1.5 hour as previously told, and they tend to suppress acid secretion for up to 24 hours because that is the time that is required for fresh production of enzymes. We could use them as enteric coated forms or powder containing sodium bicarbonate. We could use it. IV formulations are now available for all these drugs such as esomeprazole, lansoprazole, pantoprazole, and rabeprazole. And these drugs are highly bound to plasma proteins, extensively metabolized in the liver, and these metabolites are secreted in urine. Uses, as we were talking about peptic ulcer, the main use, it could be used in duodenal ulcer, the gastric ulcer, bleeding ulcers, H. pylori associated ulcer, stress ulcer, and NSAID-induced ulcer. It could be used for gastroesophageal reflux disorders. It could be used for Zollinger-Ellison syndrome. The common adverse effects associated are not much to talk about. It has headache, diarrhea, and abdominal pain because of its sulfur moiety. It can lead to skin rashes and arthralgia. There is all possibility that it could decrease the vitamin B12 absorption. It could increase the rate of infection and fracture of bone. It has interaction. Omeprazole inhibits the metabolism of phenytoin, warfarin, and diazepam. So there are certain drugs that even tend to decrease the bioavailability of this particular drug, being some of them, namely being itraconazole and iron salts. Talking about the prostaglandin analogs, so the prostaglandins PGI and PGE2 are produced by the gastric mucosa. They tend to suppress, they help in forming the mucus layer over gastric and duodenal mucosa, and they suppress the gastric acid secretion, stimulate formation of bicarbonate and mucus, and promote blood flow. Now, these drugs, they have a lot of side effects because they are produced locally. They have diarrhea, abdominal cramps, uterine bleeding, abortion, and multiple daily doses are required. The drug, it would be a drug of choice for NSAID-induced peptic ulcer, but it is not used because multiple doses are to be used for this particular drug. Talking about antacids, it could be systemic or non-systemic. We talk about non-systemic first, such as aluminum hydroxide, magnesium hydroxide, or calcium carbonate. Now, they go by the simple chemistry formula of acid plus base is equal to salt and water. So these are weak bases that tend to neutralize acid, but they do not decrease the acid production. They are over-the-counter available drugs, the OTC drugs. And their action depends upon the presence of food in the stomach. If there is no food in the stomach, the duration of action is 30 to 60 minutes. And if food is available, it could take 2 to 3, the drug could have its action for 2 to 3 hours. So these are over-the-counter drugs, and they are used for symptomatic relief, for pain and acidity of dyspepsia. Even they are used for gastroesophageal reflux disorder for off and on phenomena. Now, there is one precaution that we need to take whenever we are talking about antacid is that whenever you want to prescribe antacid, there should be at least a gap of 2 hours between the intake of antacids and proton pump inhibitors or H2 blockers. There are certain side effects associated with this. Now, aluminum antacids can cause constipation, and they can also lead to hypophosphatemia. So they would relax the gastric smooth muscle, and this would lead to delayed gastric emptying. Whereas magnesium antacids, magnesium salt containing antacids could lead to diarrhea. And supposedly there is a patient who is on renal failure. If aluminum antacid is given to this particular patient, there are all possibility of aluminum toxicity and encephalopathy in this particular patient. Now, what we do is we tend to go for a combination. Why do we want to go for a combination? Supposedly, I combine magnesium with aluminum. So it would provide a relatively fast and sustained action. Magnesium hydroxide is rapidly acting, whereas aluminum hydroxide is a slow acting drug. We could go for a combination because magnesium hydroxide would lead to diarrhea, aluminum hydroxide would lead to constipation. Combination of both would take care of these symptoms. Obviously, a combination would decrease the dose and the amount of systemic toxicity would decrease. Now, there are a lot of interactions with this. They tend to alter the pH, and so they should not be combined with H2 blockers, iron salts, and tetracyclines. And I've already been highlighting this particular that there should be at least 2 hours of a gap between before and after ingestion of drugs with antacids. The other drug that can be used is sucralfate, which is an aluminum salt of sucrose, which is an ulcer protective drug. It tends to act best when the acidic pH is less than 4. How it does that? It tends to polymerize to form a viscous sticky gel, and this sticky gel adheres to the ulcer crater, which are already told you they are rough, and it can remain there for 6 hours. It is taken empty stomach 1 hour before meals and at bedtime. It should not be given with concurrent antacids, and H2 antagonists should be avoided because they would increase the pH, and this particular drug would not be effective. So we have already talked about this, forming an ulcer adherent complex of the ulcer site, protecting it from injury. The adverse effects associated with this particular drug are constipation, Bedouin formation, hyperglycemia, aluminum toxicity, could be seen in patients with chronic renal failure or on dialysis. Before we go for sucralfate, we require to have monitoring of blood glucose and renal function because it is causing hyperglycemia and it is an aluminum salt. So renal function is to be taken care of. Patient counseling, what do you need to take care? She should be taken empty stomach and no antacids 30 minutes before or after taking sucralfate. Another drug that is used is colloidal bismuth substrate, which is a water-soluble drug and precipitates at a pH of 5, thereby forming a layer over the ulcer. So it is ulcer protective and heals the ulcer. It forms a complex with mucus, coats the ulcer, stimulates prostaglandin formation and mucus production, and also kills H. pylori. And though it has a major side effect that it causes blackening of tongue, stool, and stool. Prolonged use of this particular drug could lead to osteodystrophy and encephalopathy. So that is why it is of not much utility. So this bismuth sub preparations, they also have antimicrobial activity against bacterial and viral gastrointestinal pathogens that we talked about earlier. And we have already talked about these fecal discoloration. There is no specific monitoring required, although counseling is required, that because there is darkening of stools or darkening of tongue, you need to warn the patient. And if patient is allergic to aspirin, he should avoid taking bismuth subsalicylate. Now, talking about the H. pylori infection, it is a gram-negative bacilli which is present in 20 to 70% and normal commensal, and it is associated with chronic gastritis, dyspepsia, peptic ulcer, gastric lymphoma, and gastric carcinoma. Drugs for eradication of H. pylori, we have a 2-week regime where we tend to use 2 antibiotics, which could be either clarithromycin, amoxicillin, tetracycline, and any of these drugs, metronidazole, tinidazole, plus a proton pump inhibitor or H2 blocker and bismuth subsalicylate. So why do we want to go for a combination therapy? Obviously, we want to prevent resistance, we want to delay resistance, we want to prevent relapse, promote healing, eradicate H. pylori. So that is why treatment is required for 1 to 2 weeks. Triple therapy is given for 40 days. These are some of the therapies that are given. Lansoprazole 30 milligram, clarithromycin 500 milligram, amoxicillin 1 gram twice daily, or you could go for quadruple therapy where lansoprazole 30 milligram, bismuth subsalicylate 525 milligram 4 times a day, tetracycline 500 milligram 4 times a day, metronidazole 500 milligram 3 times a day. And one more thing that has to be taken care is that after completion of the above regime, PPI should be continued for 6 more weeks. So this is the best triple therapy that we have. We already been talking about, and we have already been talking about other drugs that can be used, such as ranitidine or bismuth substrate. We could use tetracycline, we could use clarithromycin or metronidazole. So that's all for acid-peptic disorder. Now the drugs that are most commonly used are proton pump inhibitors or H2 blockers. Proton pump inhibitors obviously offer a better advantage as once daily regime. And we also need to take care of H. pylori. So I believe that's all from my side. And if you have any queries regarding this drugs acting on for acid-peptic disorder, I would be more than happy to answer them. You could get to me, you could get back to me on the chat box, and I will be there to answer all your queries. So till that time, all of you have a good day ahead. Thank you so much for your patient listening.